Very good afternoon, everyone again. I am here to present a case presentation with the topic of disc edema or something else in a glaucoma patient. So 61-year-old female patient presented with a complaint of redness and watering in both eyes since 3 months. On ocular history, she was using fixed drug combination of anti-glaucoma medications. On examination, her vision was 6/9 and 6/18 part in right and left eye respectively. Her conjunctiva was congested with mild papillae changes, and her lens was cataractous more in left eye as compared to right eye. On 90D, disc appeared small and hyperemic in both eyes. The pressure was 20 as well as the gonioscopy was open in both eyes. So the diagnosis we made is ocular hypertension with allergic conjunctivitis and cataract. So we have stopped all medications of glaucoma and we have given lubricating olopatadine and loteprednol. On follow-up, when patient was symptomatically better, we have done autoperimetry, OCT, fundus photograph and pachymetry with complete retinal examination. So on perimetry, the both eyes fields were reliable and it suggested of diffuse generalized depression more in left eye as compared to right eye. On OCT of circumperipapillary elevated and thick RNFL on the nasal side was seen, which gives similar look like what we see in disc edema, but the fundus photo showed a contrasting picture of intact disc margins. The OCT of GCC was non-significant. Pachymetry was 538 and 527 in right and left eye respectively. So we made 3 differential diagnoses, that it's in either disc edema, thickened RNFL or peripapillary retinoschisis. So to rule out this, we performed a horizontal linear OCT scans of disc and macula. On horizontal linear scans of disc, we have seen splitting of retinal nerve fiber layers on both the nasal side and both the eyes. And OCT macula have non-significant changes. So we made a diagnosis of ocular hypertension with isolated peripapillary retinoschisis. So what is this? Schisis is a Greek word which means splitting, and when there is an abnormal splitting in the retinal layers, it is termed as retinoschisis. It can occur in peripheral retina, macula, or at peripapillary tissue. So it is associated with X-linked retinoschisis, degenerative myopia, and other congenital optic disc anomalies. It can be located anywhere but commonly seen in inferior and superior quadrant and mostly affect the inner retinal layers. So various pathogenesis have been done, like vitreous flows through microhole along with vitreomacular traction and ocular hypertension, or a small changes in axial length with fluctuations in IOP, or thinning of optic nerve tissue which have provide a conduit of fluid entrance in glaucoma patients. So these might be the reason of PPRS. So the risk factors are either high IOP, high axial length, vitreomacular traction, glaucomatous cupping, optic disc pit, or macular schisis. So the further questions were, is it rare to find in glaucoma? Does it affect the progression? Or is there any immediate intervention needed? So various articles have documented retinoschisis in a variety of glaucoma. Major trials have also been done between its association in glaucoma. And regarding its progression is usually misinterpreted as PPRS is overlapped by retinal nerve fiber layer defect. On the left side, it is a red-free fundus photograph where only RNFLD can be seen, whereas on the right side, it is the infrared fundus photograph where 2 entities can be differentiated. The orange one is PPRS and the white one surrounding the RNFLD. So once the underlying PPRS is resolved, false thick RNFL is no more and it is present as a defect which happens to be sudden. This sudden defect can mislead as progression and hence glaucoma management. So no immediate intervention is needed, but surgical intervention is needed when IOP is uncontrolled or maculopathy is present. Its natural history is either it won't expand or it will present with a new location or it will resolve either by itself or by reducing high IOP. So the risk factors in our case was high IOP, average axial length of 24.5 and little traction. In our case, the reason of PPRA is probably because of high IOP. So mostly PPRS is overlooked in clinical practice because it is often asymptomatic in patients and on fundus examination is hard to detect. Pathophysiology is not clear and therefore we need to aware of this atypical finding. So retinoschisis is not rare. Its resolution can affect the progression of glaucoma, and if any record is present, then investigations before its development and after its resolution can help in assessment of actual progression. These are my references. Thank you, everyone. Yeah, it has been reported. Uh, Percentage of PPRS and maculocysis. I don't know about the percentage, but they have reported cases of maculocysis with PPRS. So in our case also, probably if we'll follow her up more, then probably we can find maculocysis in like future. Probably, like not sure.
Right, because if you find a case of retinoschisis or macroschisis, so do we really need to look at the peripapillary area? That's why I asked you the question. And why not?
Okay, yes ma'am, why not? Because if optic disc anomaly is there, we see maculopathy abnormalities. So if only optic disc anomaly is there, then it's like vice versa. We have to rule out both. OCT images. Acha, OCT, okay. Sorry, sir? I think so. Signal strength is suggestive of reliable OCT. And yes, sir. Please go on, sir. Signal strength is 8 and 7, sir. Yes, sir. Okay. Okay. Okay, like. Okay. Yeah, yes, sir. Yes, sir. Mm-hmm. Okay, yes, sir.